Hello friends, welcome to the series of Academy of Carnivals, Me and My Hysteroscope. Everyone here will agree that hysteroscopy is providing step-by-step treatment to all tough situations of obstetrics and gynecology. Today we are going to discuss management of submucous myoma by hysteroscopy. Me and My Hysteroscope enter the uterine cavity with great vigilance and always analyze the myoma location and size. Attention on distension, pressure, watchful for bleeding and unforeseen troubles. But remember, hysteroscopy will guide to deal with submucous myoma. And for this important session, today the man behind the machine is Dr. Andrea Tinelli. Namaskar. So today's faculty is Dr. Andrea Tinelli from Italy, an amazing friend of mine, very happy, loving and always smiling personality. Academics and surgical skills go hand in hand with him. He is recognized worldwide expert in fibroids. He is Chief of Department of OB/GY, Veris Delli Ponti Hospital, Lecce, Italy. I am proud to share that I have contributed one chapter in one of his books. He is an academic rich person. Work with academic mind with skillful hands. The success will follow you. Welcome Dr. Andrea in this world of hysteroscopy.
Hi Sushma, I'm Andrea Tinelli from Italy, your friend. A big hug to all of you in India from Italy.
Thank you. Can you please show your working place in your hospital?
You can see my room when I get in, and this is my table, my PC. There's another table with chairs for a conference, and books, and so on.
That's nice, Dr. Andrea. So, now today we are going to learn or discuss about submucous myoma and its management by hysteroscopy. We know that submucous myoma is a challenging entity for the hysteroscopist. Patient presents with abnormal bleeding PV and diagnosis is by ultrasonography. By color Doppler, typically we see the peripheral vascularity and we can confirm the diagnosis. Dr. Andrea, you are expert in myoma. Can you please tell us what type of myoma we can deal with hysteroscopy?
First question, which type of myoma you can deal with hysteroscopy? Endoscopic approach by hysteroscopy or laparoscopy are the preferred methods for uterine fiber removal. Submucous myoma represent one of the main indications for relative hysteroscopy. Generally, the presence of submucosal fibroids. In the presence, hysteroscopic resection is simple, safe and effective treatment. Based on FIGO classification, submucosal fibroids as G0, G1 and G2 can be enucleated by hysteroscopy. Some fibroids can be enucleated in office setting, while others should be removed in the operating rooms in narcosis.
Okay, submucous myoma of G0, 1, 2 can be managed with hysteroscopy. But size of the myoma also matters. Can you please tell us what size of myoma can be dealt with hysteroscopy?
Second question, which size of myoma which can be dealt with hysteroscopy? Hysteroscopic myomectomy is an effective procedure that allows the removal of the submucosal fibroid almost always in a single procedure. The fibroid's diameter plays a crucial role in completing the hysteroscopic myomectomy in a single step. For less than 2 centimeters myoma in G0 fibroids, the base of myoma is resected at the endometrial level, and fibroids are resected in only one surgical procedure by classical slicing. A diameter more than 3 centimeters in G2 fibroids results in higher risk of multiple procedures. Concerning type 1 and type 2 myomas, the need for multiple procedures occurs mainly in type 2 myomas. Myomas with intramural development should be better treated with cold loop techniques invented by Ivano Mazzoni, my big friend of Italy.
Okay, you rightly mentioned about difficult myomas like G1, G2 will require multiple procedures. Can you please explain about second stage or second look hysteroscopy?
Third question, the role of a second stage and second look hysteroscopy. Traditionally, the intrauterine adhesion occurred most commonly after hysteroscopic lysis of adhesion and myomectomy, and they are present also during hysteroscopic polypectomy in a less percentage. Second look hysteroscopy in office is an easy and effective procedure for diagnosing and removing newly formed intrauterine adhesion. Few studies have focused on second look office hysteroscopy as a preventive measure of postoperative intrauterine adhesions, and only a small number of patients were included. The second look hysteroscopy could prevent the development of moderate and intrauterine adhesions and therefore improve reproductive outcome. Routine early second look myomectomy, second look hysteroscopy, should be recommended for all women undergoing hysteroscopic resection for myomas, polyps, or synegia within 6 to 8 weeks after surgery.
That is true. Then what are the hysteroscopic methods to deal with submucous myoma?
Question 4. Hysteroscopic methods to deal with submucous myoma. The transcervical resectoscopic myomectomy tcrm by hysteroscopic resectoscope is the most widely used tool. The resectoscope consists of 26 French gauge other sheet diameter and 0 to 34 oblique telescope with a 4 mm outer diameter. tcrm can be monopolar with an electrolyte poor distending medium such as glycine 1.5% or sorbitol 3%, or bipolar, most commonly used, with the use of isotonic saline solution energy. Bipolar hysteroscopic myomectomy may be a well-tolerated alternative compared with a monopolar hysteroscopic myomectomy. There are 3 basic methods for removing fibroids under hysteroscopic direction: morcellation, cutting with electrosurgical loop by monopolar or bipolar electroslicing at 100 watts, and the last one, vaporization, does not produce any tissue fragments. It is always important, remember, to avoid damage to normal endometrial tissue, please.
Very nice. But to have a smooth procedure, submucous myoma will require pre-op preparation. So what pre-op preparation do you recommend?
What preoperative preparation needed for myoma? Using GnRH analog or selected progesterone receptor modulator, mifepristone or uribristol acetate, prior to surgery, allows the surgeon to operate when the endometrium is thin, which can reduce operative time by allowing better visualization during procedure. Theoretically, it is also reduced intraoperative bleeding and fluid absorption. However, its main proven benefit is that it can reduce menstrual blood loss and correction of anemia prior to surgery. This also aids with restoration of hemoglobin and iron stores for the women.
Now, what type of cervical preparation is required before transcervical resection of submucous myoma or tcrm, or what drugs are used after tcrm?
Cervical preparation before tcrm or drugs after tcrm. Methods are available for preoperative ripening of the cervix prior to hysteroscopic resection to reduce the risk of cervical tears and uterine perforation that is associated with forceful dilatation. These risks are increased in postmenopausal women, for those without previous vaginal delivery, and for women with previous surgery for cervical surgery or neoplasia. Option for tcrm. Cervical ripening before tcrm include laminaria TENS, preoperative prostaglandins such as misoprostol, and intraoperative intracervical injection of dilute vasopressin. Misoprostol is a synthetic prostaglandin E1 analog, 200-400 micrograms taken orally or vaginally 12-24 hours before surgery, facilitates cervical dilatation and minimizes traumatic complication in premenopausal women.
Dr. Andrea, we know that as compared to other hysteroscopic procedures, TCRM is associated with more complications. So, what are these complications?
Complication after a TCRM. Bipolar TCRM usually can be complicated by intraoperative and postoperative bleeding, uterine trauma such as perforation, gas embolism, and infection with associated uterine synechia. Perforation of the uterus can occur with dilatators, without careful mechanical grasping, tools, and a receptoscopic system. Laparoscopy must be performed if bowel injury is suspected, where there appears to be a large perforation or in presence of heavy bleeding. If continuous bleeding after resection is present, a Foley catheter can be inserted in the uterine cavity and distended up to 40 ml of saline until the bleeding settles from a tamponade effects. The balloon can be removed if the bleeding has settled in a few hours. Additionally, monopolar potential surgical complications include a fluid overload with serous fluid and electrolyte imbalance, pulmonary and cerebral edema that can be identified during CT scanning from an internalization of only 500 mm, cardiac failure, and death.
Complications during operative procedure is very traumatic for the doctor as well as patients. So, how to minimize these complications?
How to avoid or minimize complication? The first rule of surgery is primum non nocere, as Latins say. First of all, never dare with fibroids that you are unable to remove safely. Always adequately evaluate the patients, whether young or reproductive age, norivorous or not, such as nulliparous, or in menopause, for crossing the cervix without complication. It is recommended to use bipolar surgery if you do not have sufficient surgical skill. Adequately assess the type of fibroids to be removed, G0, G2, the diameter of the fibroid to be enucleated, the minimum distance from the serosa, and the skill of surgeon.
You have explained very good preventive measures. But suppose there are complications like perforation, bleeding, then how to manage these complications?
How to deal with complication? If perforation occurs with mechanical instruments and no bowel injury is suspected, the patient can be managed expectantly with close observation for 24-hour period. If perforation occurs with an activated electrode, one has to assume that there has been a bowel injury until proven otherwise, and laparoscopy or laparotomy is recommended. For bleeding, pharmacological agents that have been investigated to reduce blood loss and myomectomy include tranexamic acid, prostaglandin E2 analogs such as misoprostol and dinoprostol, Unintentional activation of monopolar or bipolar puddles can cause serious thermal burns to the abdomen, perineum, vagina, or vulva.
That means we should be prepared with all gadgets. But being an expert, what are your tips and tricks for adequate tcrm for all hysto lovers?
Tip and tricks for adequate tcrm. The intrauterine pressure can be maintained at the lowest pressure that allows good visualization for performance of the hysteroscopic myomectomy. Use bipolar energy to avoid non-conducting electrolyte-free distension mediums such as glycine 1.5% or mannitol 5% at risk of fluid overload. A meticulous fluid balance should still be always maintained to check fluid overload. Thermal burns can be prevented by making sure not to activate the electrode while it is being advanced into the endometrial cavity. Post-operative adjuvant therapy, including estrogen therapy for 4 to 8 weeks or insertion of intrauterine device, pediatric Foley catheter, or other balloon for 1 week postoperatively, have all been used to prevent further adhesion development. However, there is scant evidence to support the use of this postoperative therapy.
Thanks a lot, Dr. Andrea, for your wonderful talk.
Dear Sushma, thank you for your invitation and for your interview about hysteroscopy. That is one of my first patients. Thank you. Bye bye.
So, dear friends, here we end our session. But remember, while operating submucous myoma, use your clinical acumen, be alert, analyze the size of myoma, ready with all instruments and gadgets, and always remember fluid overload, surgical time, and bleeding. You can manage, remembering all guidelines. Thank you.